Hello everyone, I am Dr. Lahari and this is the fourth and the concluding part of red and white lesions of the oral mucosa management aspects. In the previous few classes, we had learned the categorization of red and white lesions. We also discussed about potentially malignant disorders, and we looked at some of these potentially malignant disorders in detail, along with the histopathology of epithelial dysplasia and grading of epithelial dysplasia, and also how it is important to choose the appropriate treatment options. The classification of red and white lesions, which we based on etiology, were dividing them into infections, potentially malignant disorders, immunopathologic diseases, allergic reactions, toxic reactions, and reactions to mechanical trauma and others. So what we will do now is to look at few examples of cases and how we could formulate a treatment plan looking at a case clinically and trying to give it a diagnosis, as well as formulating a treatment algorithm to say something like that. So let's first look at management of white lesions. This is the case that we have discussed previously. I just thought I'd bring it to light again. This is a 56-year-old female patient who is on dialysis, who appeared weak and anemic on general physical examination. She was observed to have neglected oral health, which means there was a lot of local factors along with caries and high risk of periodontal disease. There were large areas of white scrapable lesion which left pinpoint erythema upon scraping or upon removal. So the provisional diagnosis for this is oral thrush, or which is pseudomembranous candidiasis. So if you look at the picture, it is a predominantly white lesion, but it is scrapable. Now when you look at this condition, for this case for example, this is also a white lesion on the gingiva, which is of a 45-year-old female who has undergone knee joint replacement surgery and had an incidental finding of an asymptomatic white lesion on the attached gingiva. Now, what you observe here is that the rest of the mucosa is sparingly involved, yet the gingiva is one in the posterior first quadrant is having a thick keratinized white appearance. In this patient, incidentally, there were other multiple sites also with non-scrapable, thick and irregular appearance of the mucosa, and the patient did not have any history of tobacco usage or any drug allergies. So when you're looking at a picture like this, multiple sites, white area, thick, keratinized, looking irregular, the provisional diagnosis of proliferative verrucous leukoplakia was thought of. And indeed, actually, when we did the biopsy for her, she turned out to be having severe dysplasia. And of course, the patient was kept on follow-up for a long duration, and all the white areas were excised. So this brings us to the algorithm of management of oral white lesion. So when you look at a predominantly white lesion, what should we do? First of all, it's important to identify whether the white lesion is scrapable or not scrapable. When you're deciding this, there is you have to keep in mind the history and the clinical examination of the case as well. So a non-scrapable white lesion, you would look at, first of all, either eliminating the possible cause of the white lesion and give it 2 to 4 week time for the lesion to subside or disappear completely. And in case there is no possible cause to be eliminated, you need to look at a definitive clinical diagnosis. In case of a scrapable lesion, it is most likely pseudomembranous candidiasis, or we're looking at food debris. So pseudomembranous candidiasis can be controlled by antifungals, and obviously if there is an underlying cause, you will look at that as well. When we're talking about eliminating possible causes, What would those be? Generally tobacco, chemical in burn caused by accidental chemical exposure, trauma to the area from biting, cheek biting, which we call as morsicacio, a denture which is ill-fitting and leading to friction in that area causing frictional keratosis, or maybe it could be Epstein-Barr virus leading to hairy leukoplakia. So when you eliminate these causes, there could be either good response and you know that you're looking at a definite lesion which could be managed, or you could have no response at all and then you're looking for a definitive clinical diagnosis. Now, when you're looking at good response and the lesion heals, it could be tobacco which the patient quits completely and you're having a homogeneous leukoplakia healing completely. Or like I said, trauma causing frictional keratosis or morsicacio, or you're looking at hairy leukoplakia which can heal after the Epstein-Barr virus is treated. So here we're looking at quitting the habit, replacing a denture, managing the viral infection and the lesion subsiding. On the other hand, you could have a situation where even after elimination the patient doesn't heal. So you could have the situation again in a homogeneous leukoplakia case where it doesn't heal, or you could be looking at oral lichen planus, which I have written down as OLP here, and the white component being either reticular, papillar or plaque-like. It could also be OSMF or a white sponge nevus. When we're talking about a situation where it is a non-scrapable lesion and you cannot think of any possible causes, then you're already looking at leukoplakia because you have ruled out all possible causes. And that's what the definition of leukoplakia says, that it is a lesion where no other cause can be explained. So in either case, when you're having a no response or a lesion which you cannot define, it's important to perform a biopsy. Remember, we're talking about a complete white lesion here. When you perform a biopsy, you could have two outcomes to it. First of all, you could have again a lesion which cannot be defined and you're either looking at dysplastic or non-dysplastic areas, or you could have a definitive diagnosis that comes out as a lichen planus, or you know clinically that it looking like OSMF and definitely, and on biopsy also it looks like OSMF. So that could be the two possible outcomes. So when you know you're looking at a definable lesion, it's either an OPMD, that is either a leukoplakia or a lichen planus or OSMF, or it could be a lesion which is not an OPMD like a frictional keratosis or a morsicacio or white sponge nevus. On the other hand, when you know that there is no definable lesion, you're looking for dysplasia or no dysplasia, which means you're already looking at leukoplakia clinically. At this point, I would like to remind you that leukoplakia is actually a clinical diagnosis. On a biopsy, you're looking at either a keratinized area with dysplasia or no dysplasia. So if you're looking at a definable area, then you know that you're again going back to the treatment plan where you need to ask the patient to quit habit or replace the denture or keep in view. Whereas if you're looking at leukoplakia and the patient is having dysplasia or no dysplasia, after you've determined that, it's important to perform treatment, keep the patient under observation, and most importantly, follow up. On the other hand, if you're looking at an OPMD, then you could have various possible treatment aspects. If it's a leukoplakia and it is dysplastic, it's important to look at the grade of dysplasia. Is it mild, moderate or severe? If it's a mild dysplasia, then you're looking at keeping it in view and trying to eliminate the habit. If it's moderate or severe, it's important to eliminate the habit as well as do a wide excision and keep the patient under a long-term follow-up. On the other hand, if you're looking at a white lesion which is a lichen planus or an OSMF, and if they are dysplastic, it's again important to look at the grade of dysplasia, mild, moderate and severe, and do the similar kind of management. And of course, in case of lichen planus OSMF, the patient could be symptomatic. So there you add in steroids or adjuncts and keep the patient on long-term follow-up. Though this entire flowchart actually sums up management of white lesion. Now you could have more branching and more complicated, intricate branches to this treatment aspect, But what I've tried to do is give you an overall summary. I'm not saying that this is the perfect example, but this is a method of making a treatment algorithm. And depending on the clinical scenario you've been given or the kind of patient you're looking at, your flow chart is going to change accordingly. So making the treatment flowchart is a very important skill, and it indicates higher order thinking, and it also gives the person who is treating the patient, or who is just for writing purpose, exam purpose, who's correcting your answers, and understanding that you have actually looked at all aspects of treatment plan and you have not left any aspect undone, or any area which is overlooked. So this way you get a clear idea of how to manage a white lesion. Next, we move on to the management of a mixed red and white lesion. Let's look at this case, which we had seen in our clinic a couple of years ago. A 33-year-old male patient who is a refugee and working at a construction site and has a long-standing habit of flavored tobacco usage. Now, flavored tobacco in some parts of the world, in South Asia especially, is called as gutka. The tobacco is in contact with the lower anterior vestibule for the entire day. Generally, the patients keep it in their oral cavity for the whole day and keep chewing on it, and it apparently helps to act as a stimulant as well as reduces hunger. This lesion is asymptomatic, and this particular appearance where you can see that there is a white keratinized appearance in the entire vestibule with a central area devoid of keratinization is typically called as tobacco pouch keratosis. So this red and white mixed appearance would, if is currently not a potentially malignant disorder if it's tobacco pouch keratosis, but it's important to keep it under follow-up and quit smoking, otherwise it could soon turn into a leukoplakic lesion, which is a potentially malignant disorder. Case 4 is a 67-year-old edentulous male who is a security guard by profession and has a habit of smoking cigarettes since the last 30 years. So that's a chronic cigarette smoking habit. And he smokes up to 2 packs of cigarettes a day, which is quite a bit, can go up to 20 to 24 cigarettes a day. He does not use his dentures when he is smoking. So what does it mean? It means that the cigarette smoke is in direct contact with the palate, and the denture, which would have acted as a barrier, is not acting as a barrier anymore. So there is a mixed red and white lesion which is noticed on the hard palatal mucosa, and this is asymptomatic. So you would observe that in the more towards the soft palate region, closer to the soft palate region, closer to the junction of hard and soft palate, you see a mixed red and white appearance, and the rest of the palate is actually showing you smoker's palate. So this appearance is that of speckled leukoplakia, and definitely this lesion should be biopsied. Case 5 is again a different situation where you're looking at the gingiva of a 37-year-old lady who reported with history of burning sensation. So this case is symptomatic. Now this is also a red and white lesion, but this is symptomatic. She is unable to tolerate spicy food, and pain numbing oral gels, the ones which you buy over the counter, only give her temporary relief, and they're not really helpful. She has also noticed itchy scaling areas on the skin of the back and legs, and occasional burning micturition is also noticed. Now this gives us an idea that the patient is having a more dermatological as well as involvement of other areas. This clinical appearance of redness of the mucosa, specifically the gingiva, the attached gingiva as well as the marginal gingiva with a few white areas, and in some cases you will be also able to see some striae where you should be looking out and for striae, and this kind of appearance is generally bilateral, and this is called as desquamative gingivitis. So I would like to remind you again that desquamative gingivitis is a clinical appearance and is not a diagnosis on itself. One of the provisional diagnoses could be a lichen planus. In this case, it is looking more like an erosive lichen planus because of the red component in it. Case 6 is also lichen planus, but this is slightly different. It is seen in a 57-year-old male who reported with pain and burning sensation in the entire mouth. It is associated with irregular ulceration, so he had noticed the presence of ulcers in his mouth. He has been using topical steroids already and was in a remission phase for a few years. But recently he has had a loss of his job, because of which there is lack of sleep and stress, and due to which oral lesions have also been exacerbated. Now, this is a very typical pattern of lichen planus which undergoes remissions and exacerbations. You must understand that there is an immune component to this disease, and is very much associated with the stress levels. So in this case, in the photographs, you can see here that there are bilateral white areas, thicker than the ones you've seen in the previous case, which gives us an idea that this could be plaque-like lichen planus lesions. And also on the palate, you see that there is a mixed red and white appearance, which is the erosive component of the lichen planus. So a lichen planus lesion, or a patient with lichen planus, could have multiple types of clinical appearances of lichen planus at one time. The choice of biopsy is generally the area that is close to this most severely affected. So if you're seeing an erosion or an ulcer, you should include part of the erosion ulcer and part of the normal mucosa as your area of biopsy. With this in mind, let us look at the management of red and white lesions. I have again tried to make a flow chart, so it gives you a kind of an algorithm to go about any case of red and white appearance. So when you're looking at a case with red and white lesions, you're not generally looking for scrapability here. What you're trying to look at is whether the patient is symptomatic or asymptomatic. So history and clinical examination again are strong determinants for this decision making process. If the patient is asymptomatic, you're looking at again eliminating possible causes. Give the case about 2 to 4 weeks time for the cause to be eliminated and the lesion to subside. On the other hand, you could have no definitive cause or no possible cause associated. If the patient is symptomatic, then you're already straight away looking at giving a differential diagnosis of one of the conditions. You could be having oral lichen planus, OSMF, which is showing you both red and white areas, SLE, erythematous candidiasis, and other examples, but I've just listed the most common ones here. When we're talking about eliminating possible causes, we're going back to the same ones again, like tobacco, chemicals, or drug induced, or trauma, or a restoration, which could be the cause for a lichenoid reaction. If you're having a good response, then yes, you're already looking at either eliminating tobacco and the lesion was a reaction to smokeless tobacco. Speckled leukoplakia, which could also subside in some cases where the person actually quits the habit, a chemical burn, lichenoid contact reaction, or a drug-induced lichenoid reaction. If there is no response, then yes, you're looking at speckled leukoplakia or a lichen planus, OSMF, or SLE, which do not heal with the stoppage of the habit, or in case there is a habit or a definitive cause. Now, if there is no definitive cause, then you definitely know you're already looking at speckled leukoplakia. In either of these cases, it's important to do a biopsy. And many a times it is very difficult for your patient to comply to the fact that you want them to eliminate the cause, reduce the habit, or you've tried to reduce stress levels. These things generally don't work for all patients. So you should decide to do a biopsy when you know that the lesion is having both mixed red and white appearances, as the malignant potential of that lesion would be higher. When you perform a biopsy, you're either seeing a definable lesion or a no definable lesion. When you know that there is either a definable or no definable lesion, it's important to perform a biopsy and understand that there could be dysplasia in either of the cases or no dysplasia. When you're looking at dysplasia, again you're grading it as mild, moderate and severe. And if you're looking at dysplasia and it's a speckle leukoplakia, then again we're going back to either quitting the habit if in case it's mild. If it's moderate to severe, you also have to quit the habit, perform wide excision, follow up the patient, keep the patient on some antioxidants, and keep the lesion under follow up for a long duration. In the fact that there is no dysplasia, you are looking to treat the lesion and keep it under observation and eliminate the cause. So that's why I've drawn another arrow mark which connects it to the fact that it's important to keep it under follow-up. On the other hand, if you're looking at a definable lesion like a lichen planus, OSMF, or an SLE, and they are dysplastic, again it's important to keep in view if they are mild. Try to eliminate the cause if it is possible. If moderate or severe, important to treat symptoms in these patients, especially with steroids and adjuncts, and follow-up. So follow-up is a very important component of all of these lesions. It's important to keep the patient under constant review, call them back in the first year for every 3 months to 6 months, and then later moving on to about review every year. So I have tried to give you, again similar to the white lesions, a broad overview of how to manage red and white lesions. This should serve as an example of how to exactly formulate treatment planning with the help of a flow chart. You could again have various branches to it. You could make your own branches depending on the situation and the case that is presented to you, and make it more complex or less complicated and fitting to the example that has been given to you. Right, so thank you for listening to me. I have used Van der Waals' example of the basic flowchart as an example to create more branches out of it. If you still have doubts, don't feel free to contact me. I'll be happy to clarify them for you. So that's it from me.